Okay, it is now 4 o'clock and I guess we can start. Good afternoon, everyone. Good afternoon, Dr. Rivera, Dr. Cristina Laureta, and Dr. Joan Marañon, and Gil also from France. Do you hear me well, ma'am and sir?
Yes, perfectly.
Okay, hello everyone. Good afternoon to the webinar of Dr. Jose Manuel R. Rivera from the University of the Philippines College of Dentistry Graduate Program in Orthodontics. He is a professor in our university. We also have here Dr. Cristina M. Laureta and Dr. Joan Marañon, also professors from the University of the Philippines Manila College of Dentistry Graduate Program in Orthodontics. Dr. Cristina Laureta is also our college secretary at the University of the Philippines Manila College of Dentistry. Welcome, ma'am and sir, and hello from France. Okay, ma'am, please be honored to introduce our speaker of the webinar today.
All right. Can everybody hear me? So good afternoon to everyone. It gives me great pleasure to introduce the speaker of today's webinar. Dr. Jose Manuel Rivera was graduated from the University of the Philippines, Manila, with the degree of Doctor of Dental Medicine in 1992. He ranked number 1, or he graduated from the top of his class from among 55 graduates. In 1996, he earned his master's degree in orthodontics, also from the same university, from the graduate program in orthodontics of the UP College of Dentistry, University of the Philippines, Manila. He served as the Association of Philippine Orthodontists president from 2008 to 2010. And in 2018, he served as the LOC chair of the Asian Pacific Orthodontic Conference, which was held in Boracay, Philippines. This was the Philippines' first international orthodontic conference, which was attended by more than 800 delegates from 20 different countries. Since 1997 up to the present, Dr. Jose Manuel Rivera has served as a faculty member of the postgraduate program in orthodontics at the University of the Philippines College of Dentistry. Without further ado, I give you Dr. Jose Manuel Rivera.
Thank you, Dr. Loretta, for that kind introduction. Welcome colleagues, friends from around the world, and students in orthodontics who are participating today. Now, before we start, I would like to first thank Ortho Partner and Dr. Femdum Lau of DDM Infinity Enterprise for inviting me once again to lecture. Now, actually, this lecture of mine was given last September 22 in Paris, France, during the Genius Summit. Okay, so for today, we will be talking about mandibular lateral displacement, or commonly known as MLD, the different etiology and treatment modalities. Okay, now these are the two favorite places that I would certainly want to go to now, but unfortunately we are all in lockdown. I hope everyone is well and safe in their homes listening to this lecture. So my two favorite places, Boracay, Philippines, and Paris, France. Okay, now the Philippines and France share a lot in common. Beautiful smiles and beautiful people. Alright, so as mentioned by Dr. Loretta a while ago, I've been teaching at the University of the Philippines since 1997. The University of the Philippines was the first university to offer the program in orthodontics, the master degree program in orthodontics. It's a 2-year program. We accept 5 to 8 students a year. So for those students who are listening in or those who are interested to pursue orthodontics, please do not hesitate to contact me or go to our website or go to the Facebook page to get more details about our program. Alright, so to start, so the lecture, as I said, is on mandibular lateral displacement, its varied etiology and treatment modalities. Now, as orthodontists, we often are confronted with the dilemma of how to treat such patients with MLD successfully. So today, I would like to share with you some treatment options available for such cases. Now, generally speaking, beauty of the face is associated with symmetry, but not even the most beautiful woman on earth, as you can see in this photo of Angelina Jolie, is there really a very symmetrical face. So as orthodontists, we strive to achieve the most ideal result by giving our patients a symmetrical face. And many times, this can be a challenge. So what are the MLD clinical characteristics? No? So usually patients who have MLD are characterized by the following: a deviation of the chin, facial asymmetry, dental midline discrepancy, crossbite in the posterior region, and a high prevalence of internal derangement of the TMJ, especially on the side where the mandible is deviated to. So how perceptive are we to facial asymmetry or MLD? This photo compilation shows us the varied degrees of facial asymmetry correction. It was noted in this study that orthodontists were the most perceptive in identifying facial asymmetry as compared to dentists and lay people. So it's orthodontists who are the most qualified to identify the asymmetry and to recommend treatment options. And so the treatment of the best facial aesthetic appearance for a given patient is a primary goal of orthodontic treatment. If I'm going too fast, please just raise your hand, or if you have any questions, just let me know. So the evaluation of a patient's frontal symmetry is the most critical aspect of diagnosis because this is the most appreciated view for any individual. Individuals who report for orthodontic treatment are often associated with facial asymmetry that may be greater than the acceptable norms. So such asymmetries may have skeletal or dental etiology. So we have to identify if it's skeletal, if it's dental, because that will dictate to us what type of treatment we will do. And of course, also the limitations of the case. All right. So the diagnosis, treatment planning, and mechanics for the asymmetric patient require the identification of the cause of the asymmetry. A careful differential diagnosis together with a thorough treatment plan can ensure successful treatment outcomes in the management of such cases. So what are some of the major causes of facial asymmetry? So to enumerate a few, we have congenital deformities such as hemifacial microsomia. We have developmental asymmetry such as unilateral chewing, postural habits. We also have acquired facial asymmetry, for example, a patient having TMJ ankylosis, facial trauma, or facial tumors. All right. So, based on the structures involved, facial asymmetry has been classified into 4 major categories. So it can be skeletal, it can be dental, it can be muscular, and it can be functional. Okay. When we say hemimandibular hyperplasia, so this is just to familiarize ourselves with the different types of asymmetry. When we say hemimandibular hyperplasia, half of the entire mandible is enlarged 3-dimensionally, but there is no shifting of the chin point. So as you can see from the illustration, only one side of the jaw is a little bit elongated, but the midline remains on. This is to differentiate it from the hemimandibular elongation. Okay? So with hemimandibular elongation, there is elongation of either condyle or the ramus in the vertical plane, or the mandibular body in the horizontal plane, or a combination of both, which leads to the shifting of the chin towards the opposite side. Okay, for dental asymmetry, this is usually associated with the following conditions. No? So for example, a patient with premature loss of deciduous teeth, congenitally missing teeth, presence of supernumerary teeth, and tooth size asymmetries. All of these factors can cause dental asymmetry. Now, for muscular asymmetry, this may result due to abnormal muscle structure or activity on one side of the face, such as hypertrophy of the masseter on one side of the face, giving the appearance of facial asymmetry. So these are patients or people who tend to favor one side in chewing. No? So they tend to just chew on one side, and the muscles on one side tend to develop more than the other side, therefore causing facial asymmetry. Okay, another category is your functional asymmetry. So a functional asymmetry occurs as a result of the functional deviation of the mandible in response to occlusal prematurities. Such cases include the presence of a constricted arch or unilateral crossbites. Often, a single malposed tooth may result in the shifting of the mandible during closure from centric relation to centric occlusion. Okay, so this is one way of determining whether a case is a skeletal or a functional type of asymmetry. When you ask the patient to bite down to centric occlusion, if the mandible is straight before biting and shifts upon centric occlusion, then you can see that there is a prematurity that is causing the deviation, and this is categorized as a facial or a functional asymmetry. So that's one way of differentiating it from a skeletal asymmetry. In a skeletal asymmetry, there is an asymmetry when the patient's mouth is open all the way to centric relation, all the way to centric occlusion. There is no change. So that's one way of doing your diagnosis. Alright. So in the clinical examination for MLD, the patient should be evaluated from the frontal view. So a gross evaluation of the facial proportions can be done by dividing the face into equal fifths. Along with this is an inspection of the symmetry between the bilateral gonial angles of the patient. The midline of the face should pass through the point between the eyebrows, the dorsum, and the tip of the nose, the philtrum, and the chin point. Facial midline can be assessed by extending a wire or even just a piece of floss from the forehead to the chin. A true facial asymmetry due to skeletal causes maintains the same relationship both in centric relation and centric occlusion. So that's clear. Alright, now the dental midline should coincide with both the arches with the facial and with the facial midline. The evaluation of the concordance between the midlines should be made in various positions of the mandible, such as the mouth open during centric relation, initial contact, and centric relation or centric occlusion. No? So as you can see here in the photo below on your lower left side, you can see how the mandible shifts upon centric occlusion. No? So indicating a functional type of a problem. The cant of both the maxillary and mandibular planes should also be evaluated. So the patient is made to bite on a tongue blade or even a popsicle stick, no? And is assessed for parallelism with the interpupillary plane. Okay? The threshold for recognizing an occlusal cant is 4 degrees between the plane of occlusion and the interpupillary line. So at 4 degrees and above, it already becomes obvious, not only to the orthodontist but also to the patient. No? So that's why we want to correct the problem of canting. The patient should also be evaluated for the amount of gingival display on both sides of the midline as the patient is made to smile. So remember, patients who have LLD are also associated with canting of the occlusal plane. And sometimes that's a challenge for us to correct the gum line. No? Aesthetically, it doesn't look good, even if you have a flat occlusal plane, but if the gum line is not symmetrical, then it also causes an aesthetic problem. The lower border of the body of the mandible should also be assessed for bilateral symmetry. No? So this is the best way to be able to detect it, having the patient put the chin up and take a photo for assessment. The patient is made to perform the various functional movements of opening the mouth, protrusive movements, lateral movements of the mandible, and any imbalance between the two sides is corrected. An accurate registration of the centric relation must also be made. Deflection of the mandible is movement away from the midline during opening without returning to the center during movement. If there is a mechanical obstruction, the deviation or deflection is generally in the direction of the involved TMJ. So it's just a way for us to determine what TMJ is involved. A note of the maximum interincisal opening is made along with the interocclusal gap. Temporomandibular joint evaluation is done to check any symptoms of clicking, popping, tenderness, to rule out any temporomandibular joint disorders. So the rule of thumb, if there's any TMJ problem, we initiate treatment to address the TMJ problem first before proceeding with the orthodontic treatment. If the patient is symptomatic with TMJ pain or whatever, then we have to address that first before proceeding to orthodontic treatment. So the usual diagnostic records for orthodontic treatment are taken. For the photograph assessment, the routine frontal, relaxed, smiling, profile view, and oblique view are taken. The photographs are assessed for any gross asymmetry between the two sides of the face. Of course, we also have to take the panoramic radiograph as well as the SEF to determine whether it's a skeletal or dental problem. In the panoramic radiograph, you can actually already see if there's any disproportions on the sides of the joints, no? or any discrepancy between the right and the left side. No? If there's any discrepancy, you can take additional tomograms or other radiographs to confirm your findings. A supplemental posterior-anterior cephalogram is taken to record the degree of facial asymmetry. The diagnostic measurements made in the posterior-anterior cephalogram are the following. So just to refresh our memories, which may have gone into lockdown during this quarantine. So these are the usual landmarks that we want to trace when analyzing the posterior-anterior cephalogram. So we have the frontal occlusal plane, frontal mandibular plane, the mastoid plane, the condylar inclination, the zygomatic plane, the lateral border or center of the zygomatic arch, the condylon or the most superior point of the condyle, the articulare, which is the point of intersection of the dorsal contour of the mandibular condyle and temporal bone. Okay? So just to refresh our memories. Alright. So notice here, the occlusal plane in NLD cases is inclined superiorly on the shifted side, indicating that the vertical height of the shifted side is less than that of the contralateral side. Okay? So the mandible is rotated three-dimensionally, accompanied by a tilting of the frontal mandibular plane in the same direction. So what happens here, no? Because of the shifting of the mandible? The condyles are shifted to the contralateral side. This kind of mandibular rotation can cause strong compression on the shifted side of the condyle and also internal derangement of the TMJ and osteoarthritic changes of the condyle. So it's not common, it's common for patients with NLD problems to also be associated with TMJ problems because of the compression of the joint brought about by the shifting of the mandible. Okay? The canting of the occlusal plane in NLD also causes a disproportion in the gum line that is hiding. So this is one thing, as I said, that we also want to correct aside from the deviation of the mandible. So our treatment objective is therefore to try to reposition the shifted mandible to correct the canting, the gum line, by doing intrusion and extrusion mechanics. So in this patient, the mandible is shifted to her left. No? So we want to shift it back to the right. Okay? So in order to do that, we want to reconstruct the occlusal plane. We want to do intrusion of the upper arch on the right side and extrusion of the upper arch on the left side to be able to correct the canting, to correct the occlusal plane, and to try to shift the mandible back into its position. But of course, there are limitations to doing this. No? So probably in a mild skeletal MLD case, this can probably work. But in a moderate to severe case, probably not. No? Some patients do not agree to surgery. So we just try to do the best that we can to achieve a symmetrical face as much as possible. No? So there will always be limitations for a moderate to severe case if you do not do surgery. Okay? Alright. So dentofacial asymmetry is due to one or a combination of the following factors. So it can be dental arch, skeletal, or functional. Corresponding treatment for each factors are the following. So again, if it's a dental arch asymmetry, very easy. We do orthodontic treatment, we do asymmetric mechanics. For skeletal problems, we can do orthodontic surgery together with orthodontic treatment. For functional problems, we can do occlusal adjustment, orthodontic treatment, interference removal. No? So these are our options. For dental arch asymmetry, due to a dental arch problem, we can either use elastics for mild cases, or we can even do asymmetric extraction to be able to correct the asymmetry. So I'm sure you're all familiar with Tom Cruise. So he has a midline discrepancy of actually 1-2. No? So what's the best treatment for Tom Cruise? Probably an extraction of one bicuspid on his right side to be able to shift everything to correct the dental asymmetry. Alright. So for functional asymmetric problems, occlusal prematurities causing the mandible to shift can be treated by selective grinding or orthodontic treatment. Now, of course, we do selective grinding if the tooth is just a deciduous tooth, right? So anyway, it will exfoliate. So we do selective grinding of the deciduous tooth. Like for example, in this patient, there was premature contact on the deciduous cusps. No? So by selective grinding the cuspid, a more normal occlusion was established without the mandibular shift. No? But for permanent dentition, of course, we can resort to comprehensive treatment, orthodontic treatment to be able to correct the bite. A lateral functional shift may occur because closure of the mandible in centric relation causes the opposing cuspid to contact in a cusp-to-cusp position. Because the patient is unable to occlude with the teeth in such a position, the mandible is shifted laterally to allow contact of more occlusal surfaces and to improve function. So this is commonly found in patients who have crossbites, no? Unilateral crossbites or bilateral crossbites. They cannot occlude properly. So the mandible tries to adjust by trying to shift to the most comfortable position. No? So that's where the functional shift takes place, when the mandible tries to adapt to the malocclusion. No? So by correcting the malocclusion, by removing the interferences, we can easily correct a functional shift of the mandible. Okay, so management of posterior crossbites in pre-adolescents. No? So these are our options available. We can do equilibration to eliminate the mandibular shift. We can do expansion of the constricted maxillary arch. We can do unilateral repositioning of the teeth. And we can let the patient wear a functional appliance, such as an onlay appliance, which I will be discussing next. Okay, so this is a 5-year-old patient that was treated with a functional appliance or an onlay appliance to be able to correct the MLD problem, no? The functional MLD problem. So this case was shared to me by my professor, Dr. Cynthia Pisbundang. No? Alright, so notice the shifting of the mandible to the patient's left side. No? So the patient is only 5 years old. Right? Okay. So intraorally, you can see that the patient is exhibiting an anterior crossbite and also a left posterior crossbite. Okay, so the photos here show us the difference between the patient in centric relation and centric occlusion. So remember, previously I mentioned to you that this is one way of determining whether the problem is a skeletal problem or a dental problem. So here, when the patient's mouth is open, it is actually symmetrical. No? But when the patient is asked to bite down into centric occlusion, the mandible all of a sudden starts to shift and deviate. No? So this was diagnosed as a functional shift of the mandible. Of course, there is also maybe a class 3 component to the case, no? A mild class 3 component to the case, which resulted to the anterior crossbite. Okay, so how do we fabricate the onlay appliance for this patient? So the first thing that we have to do is to take an impression of the upper and lower teeth. No? And then we take a bite registration with the patient occluding in an edge-to-edge position in a retruded manner as much as possible. No? So it actually is the same principle in taking a bite registration for any type of functional appliance. No? So we let the patient sit up on the dental chair. First, we practice the patient on how to bite properly into the proper symmetrical position in an edge-to-edge position. There are actually even some devices like the ProChet appliance that can help you take the impression more accurately, etc. No? But usually we can just use softened pink wax stabilized by maybe a bite stick to be able to get the accurate bite registration. No? So we take the impression of the upper and lower arch, we take the bite registration into an edge-to-edge position or slightly open position, maybe 1 millimeter, with the mandible in the proper position skeletally, no? Symmetrical position. Okay. So we transfer this to an articulator. Okay, so here we can see that the casts were already mounted into the articulator, and the byte registration guided us in mounting this to the articulator. Alright, so the next thing we have to do is do a wax up of the primary, first, and second molars. Okay, so as you can see here from the photograph, when we try to move the mandible to its proper position, and when we ask the patient to bite into an edge-to-edge position, there are spaces at the back, right? The teeth do not occlude. So here we want to establish a good occlusion with the wax up of the primary, first, and second molars. So we are actually creating a favorable occlusion to be able to normalize the muscles of the face, to normalize growth, to normalize the dentition as they erupt. No? So the wax has to be carved properly into correct occlusion, into correct anatomy, because that will also guide the mandible to stay in that position. No? So we're guiding the mandible to go back to its correct position. Remember, this is a growing patient, so we can still modify growth, we can still modify the eruption of the teeth, and so on. Alright, now this is just an example of how to do the wax up and how to do the impression and fabrication. No? So this is done on the upper arch, but actually we're working on the lower arch. No? So this is just an example. So you might be wondering why this is the upper arch. No? Okay. So you take an impression of the waxed up teeth with the rubber impression. So you can use Exaflex for that. You remove the rubber impression material. So as you can see, like a shell, you'll have a shell mold to be able to pour your acrylic into. No? And then you remove the wax buildup from the tooth. You transfer this tray that you have created with your impression material and your self-curing acrylic back to the deciduous teeth to be able to form the crowns that we want. No? So this is how it's going to look like. So these are actually the crowns, how it will look like after the self-curing acrylic is trimmed and polished. No? So we mix self-curing acrylic and put it in the rubber impression material and adapt it to the lower working cast. No? And then we trim it, we polish it, and we're ready to install it on the patient. So actually this procedure, if you're uncomfortable doing, you can actually send this to the laboratory for them to fabricate it. No? You can use self-curing acrylic, or you can actually use heat-cured acrylic, which is actually stronger. Okay, so here we have already cemented the acrylic on the occlusal surfaces of the lower primary teeth with glass ionomer. Okay, so as you can see, just by cementing the onlay, the patient now is able to guide his jaw into the proper position because of the correct anatomy of the wax-up pontics that were created. Now the bite is a little bit open to allow the development of the upper arch, to allow a more favorable growth of the maxilla and correction of the asymmetric problem. No? So, functional matrix theory, you alter function, you alter form. No? Okay. Okay, so the photos here document the case. The upper photos are your NLD pre-op photographs with the crossbite and the shifting of the mandible. The second line of photos, here you will see the patient after the appliance or the onlay appliance cemented. Then after 1 month of progress treatment, after 3 months, after 4 months, after 6 months, and then after 8 months. Okay? So the overlay gets actually worn down over time. So remember, this is fixed to the patient's teeth, and because of grinding, because of function, it can wear down over time. No? So if you think that it's getting worn down and the bite is deepening, or a crossbite is developing once again, then you can add more acrylic to the posterior area to raise the bite once again. Okay? So you just have to monitor the patient every month to see the progress. No? So usually we wait until the D's and the E's have exfoliated, no? And or until the upper central incisors have erupted. Okay, so the best retention is a good bite. No? So once the upper arch has developed, once the incisors on the upper arch have erupted, and you get a good overbite, then most likely the case will be stable. No? So in this case, since the patient is still 5 years old, by the time the online appliance was finished, the patient is around 6 years old. So you still have to do a little bit of monitoring because there's always going to be a possibility of relapse, no? Until the upper incisors fully erupt and you have a good overbite to maintain the occlusion. No? Now, if the patient develops into a class 3, skeletal class 3, maxillary deficiency, then you always have the option of using a face mask to bring the maxilla forward to jump the bite. No? But at this age, our main concern or our main problem was the NLD, which if we left untreated will probably cause distortion of the jaw and will complicate treatment even more in the future. No? So we've addressed the problem at age 5 or 6 in correcting the NLD problem, in creating a more favorable environment for the teeth to erupt, for the jaws to grow, for a more normal occlusion to develop in the future. Yeah? Okay, so total treatment time for this case was only 8 months. So after treatment, the bite was corrected, the symmetry was corrected, so the patient was happy. Okay. Now for skeletal mandibular shift, we have the following treatment options. So when we are confronted with moderate to severe NLD cases, it's really very difficult just to do it orthodontically. So sometimes we really have to get the help of a surgeon to be able to correct the problem. No? So what are the surgical procedures that are done for cases like this? So we have the bilateral sagittal split osteotomy and even genioplasty to correct the chin position, no? Distraction osteogenesis for growing children, and also functional appliances can work for growing children. No? So we can still mold the growth to be able to achieve a more normal development of the mandible. Okay, so this is just an example of what orthognathic surgery can do on a patient with NLD. So this case shows us a combination of surgery and orthodontic treatment in treating a skeletal asymmetry. Yeah? So again, pre-surgical orthodontic treatment was done, followed by intraoral vertical radius osteotomy and straightening genioplasty. So if you notice, the cut for the sagittal split is vertical on this case, no? Because one side of the jaw is longer than the other side. So this is one way for the surgeon to be able to correct the vertical dimension on one side of the face. And sometimes the sagittal split is not enough to correct the asymmetry. A genioplasty sometimes also has to be done to be able to get a better result. Okay, so this shows us the pre-surgical orthodontic treatment or decompensation being done prior to surgery, no? And then the lower photo shows us after surgery with the patient on finishing elastics already to get a sucked-in occlusion, no? So as you can see from orthodontic treatment and orthognathic surgery, we were able to achieve a symmetrical face, a good occlusion. No? So for moderate to severe NLD problems, the success rate is better if you do this in conjunction with orthognathic surgery. Alright, now skeletal facial asymmetry due to a congenital problem. No? A hybrid functional appliance can be used to modify growth. So another more radical option would be to use a distractor. So I'll show you how it looks like. Okay, so this is an example of a hybrid functional appliance. No? So early diagnosis is fundamental in order to intercept and correct abnormal growth, avoiding the development of a skeletal asymmetry. Skeletal jaw asymmetries can be treated by surgical therapy only at the end of growth. No? So even if we wanted to do surgery, orthodontic surgery, we have to wait until 21 years old to be able to do it. And sometimes the patients, are conscious about their appearance, function is affected, they want treatment done. So these are options that can help the patient and even help reduce the severity of the problem. No? So skeletal jaw asymmetries can be treated by surgery only at the end of growth, right? So in case of slight asymmetry, early intervention aimed at the correction of the asymmetry is recommended.